Morning, everybody, and thank you very much to Brendan University for inviting me here this morning. And as Brendan said, it is very hard to say no, and it's great to be in Galway. I'm from Sligo myself, so it's great to be back in the West. I suppose what I want to present to you this morning, the paper, I've termed it how lean management can transform our hospitals operate. But I want to talk to you about, and I don't really want to get bogged down in lean management per se and the structure of lean management. I want to talk to you about maybe how how we've used lean both in the matter and how now I'm trying to transform it into the group as a hospital operation, how to improve operations across the hospital. And I suppose there's some components in this presentation that I might just rather look at asking questions, and I think it'll be maybe more developed in the following presentations, is looking at what we've seen, some of the work we've done, that actually we have created a lot of data, and this is very much data from how we're improving the processes. And I think just some of the conversation I had earlier this morning with one of the speakers, I think outcomes is very valuable, because we do get caught up a lot about how we improve the process, which is very important. It's very important to me as a hospital manager and a manager of a group of hospitals. But at the same time, we also want to introduce some outcomes into the work that we've done. So I suppose we got, what I like about, the whole lean management drive is that it's all about adding value, and those of you who are familiar with lean management, it's a process that initiated in the manufacturing industry with Toyota. It's not really evolved very well into healthcare. You get pockets of it in different parts of healthcare, and the journey we set out in the Mater Hospital at the time, a couple of years ago, was to become the leanest hospital in Ireland, and that was based on some work I saw in the UK through Bolton, where I engaged with the CEO there. I remember going to a presentation of the Bolton CEO, and she talked about the work that they'd done in Bolton and how they transformed the whole operational side of Bolton Hospital, and they became the leanest hospital in the UK. So I just want to talk to you a little bit, I suppose, really of how we've used this in our journey as transformation. So I suppose, first of all, what taking away the whole manufacturing vocabulary around lean and that, I see what I see about it is really it's how we actually transform healthcare to improve value. And lean is all about adding value to the patient journey, and about, they talk about that, removing the non-value add. So I suppose from a funding point of view and from the public purse, it's about actually how do we make the best value of the budget that we have. From a patient point of view, it's about very much patient specifics. How do we remove non-value added from the patient journey? And some of the work I'll be talking to you this morning is around patient journeys. I think the interesting thing from the staff point of view, and what we've seen is when we introduce this across the hospitals, is that you're looking at engagement from staff at all levels across the organisation. And in the projects that we've run out, we've seen where everybody has a voice at the table. So where we're doing projects, we do them with a cross-disciplinary level of staff, from your healthcare assistant to your consultant to your ward sister to your admin person. And how that's evolved into I suppose, a movement of its own, where people who wouldn't normally have voices at the table actually probably have the best ideas and solutions. And then in relation, as I said, being the guardian of the public purse in relation to how can we actually ensure that we're adding value for the taxpayer. So I suppose really when we look at the principles around what we've done to date, as I said to you in the very beginning, it's very much a patient-centric model. When we introduced, we were very conscious that we didn't want to get caught up, as I said before, with the parallels with industry and manufacturing, and we had to remove a lot of the language from the templates that we were using. But it was designed around the patient. You'll see that in some of the solutions I've given you and some of the successes that we've had. And as I said, it's identified to value for the patient. And one of the key things that we have been successful in components, it's minimising time to treatment. So maybe if I just give you a little bit of contextual piece where we came from in the Mater at the time. And the Mater Hospital for those who don't know, it's about a 600-bedded hospital in North Dublin. We introduced this as part of, I suppose, a piece of work because we're moving into our new whishy building, which was a brand new state-of-the-art building, which we had moved a lot of our services across into, and we're moving very much from a 150-year-old building into a new building. And one thing we did say is that, we didn't want to, I suppose, transfer all of the processes and our ways of working across. So we had to actually change how we do things, and there was a lot of cultural change there. So it was very much an organisation-wide improvement. So, we started off looking at projects that evolved, looking how we adapt into a new hospital. There was a number of small, but actually, as you see, actually significant savings to the hospital for some of those initiatives that were taking place. We started that in about 2011, 2012 when we were moving across. And then, what we saw with the first set of projects we did, and I remember going to a conference, or actually it was one of the HDIPs that we did for leadership and quality improvement. We're saying if you do a lean program within any organisation, you don't get an outsider to do it for you. It doesn't come from the top down. It doesn't. You shouldn't be using it as a drive for another purpose. And when I thought of what we actually initiated in the matter at that time, actually, God, we did everything wrong, because we did have to use a company to come in to actually set us on the journey in relation to doing these. It was very much, I suppose, driven from the people, from ourselves, saying, we needed to do things differently. We didn't go out to the staff and ask them about it. And we, as I said, we got buy-in initially, but if you looked at actually how we did it, it wasn't sort of, as I said, the book way of doing it. But actually what we found is that we did actually get people engaged, and we did actually get people seeing that they got some value from doing this piece of work. And but also we knew that we had to do things differently than what we've done them. So I did actually put in I put in a governance structure around the whole lean piece of work. So in 2013, then when we got the initial projects off the ground, I think what I did was I set up, because we were going through a number of changes in the hospital at the time. It wasn't just moving to a new build. There was a change of management, moved into a new directorate structure. We moved our patient flow processes was changing as well. So there was a number of changes all happening at the same time. And I was conscious that we needed to have an overall vision and that development. So I did put in a transformation office for change and change management. And out of that transformation office came the Lean Academy. And really was looking at leadership and getting good people actually to drive those. So I was very fortunate that I have two excellent people, both in the Transformation Office and in the Lean Academy, who actually were able to engage with staff, were able to get buy-in and actually encourage this whole improvement piece. So, as I said, once we had that, we said we needed to put in some form of governance around the process. So we set up a Lean Strategic Board. It was very much, it was led by the top down, but we got buy-in and engagement from the bottom up because we had a process in place to enable us to engage staff at all levels. And the other thing that we actually did was that we did engage with the university. So we engaged with the University College in Dublin, and we created a graduate programme for Lean. So not only did we have the buy-in from the bottom up and we had the staff engagement, but actually we did get the university on board, and it became an established accredited programme. So what we did through that was we established a Lean Six Sigma, what we call them white belts, which is the first level of training, and then the green belt program, which is some of the projects I'll talk to you about later, is where we get projects of groups of people working together to actually work on projects and set about doing improvement initiatives. As I said to you, all the training was interdisciplinary, which I think was probably one of the most, or is today, because it's still going on, is one of the most, I suppose, rewarding pieces of this project. And we have now I think we've now over 300,000 staff trained in lean, not just in the matter but across the group. We are now creating a demand for actually lean working across, for this type of training across the hospital group. And what we've done at the moment is, as you know, black belt, if those who know about the different levels, is the highest level where of lean engagement. So I have about 3 to 4 people now trained at black belt level, and we actually now have a program with UCD which we're training to black belt level. So that's just talking about a pathway. So I spoke about this. I don't want to. So it is a quality of credit. So I suppose really what I want to talk to you about, like, so how do we go about doing what we did? So it's very much an evolutionary process. You know, it's I suppose we saw when we set up what we were doing, it's about developing a shared understanding about what we were doing, what we were trying to do, getting staff co-designers in the work, and you see that from some of the projects actually that we've got successes in. Developing that continuing in education program so that we're developing a stable structure for that improvement work. And then I think the big piece about it as well that we've seen in the work that we've done is that, you know, improvement is everyone's responsibility. It's not just mine or the director of nursing or the chief operating officer or the head of transformation to say we need to improve process. It's actually everybody's work. It's everybody's responsibility to improve what we're doing. So I'm just going to skip that and come back to, if you don't mind. I just want to talk to you a little bit on actually what we've achieved. So, so as I said, we now are looking at projects across all of the organisation in one organisation, and they move from outpatient work and outpatients work, diagnostics in the corporate services side, and we're doing a big project which I want to talk about at the end around unscheduled care. But this gives you some examples, I suppose, of some of the buy-ins, of some of the results that we had. So in the outpatients time, you know, we took a clinic, for instance, and there was a clinic in particularly in one services. It was completely overrunning. It was overrunning into the evening. You know, staff were staying late. Patients were getting frustrated, as you can imagine, because they were coming for a certain appointment time. There was, you know, the levels of engagement was variable, and so we took this clinic, we looked at it, we put a key number of people together, undertook what we call a green belt, a whole process improvement redesign work, and through a redesign of the processes within the clinic, we were able to reduce the actual time by 50% and then add capacity. Because what was happening was, as clinics were staying late, this particular service was coming to me and saying we need to get more clinic time within the service. And I said, no, actually we need to look at what you're doing in the first place. So that was one of our first, I suppose, really quick wins, I suppose, out of the system. And these were all coming from every year, twice a year, we have a group of green belts who actually undertake about 16 projects a year. And this has been going on for the last 2 to 3 years. And each of these projects then are actually presented back to the leadership team, and they're endorsed in the beginning by the leadership team, then they're presented back, and then they're put into the control phase in relation to getting sustainability out of them. So I'm delighted to say that the projects I'm presenting here this morning have gone through that control phase, and we are seeing with sustainability. Other things we've done about it was simple things like looking at the ECHO report turnaround time, and again reducing that by 60% in the ECHO department, and that again was by introducing some simple processes improvement in that area. This was an interesting one because we did it at the very beginning of the transition where we're moving into the new build. Was we talked about, as I said, we were coming from a 150-year-old building, going into a brand new spanking state-of-the-art facility, all single rooms. The first thing they were saying, well, this is going to cost us X actually in the support services. And if we just look at our cleaning bill, and based on what we're cleaning already, this is actually going to increase significantly when we move across. But actually, when we actually started looking at what our current processes around our cleaning was, we were able to cut them by 20 20 minutes to 30 minutes per ward. So therefore, what we were going across with was a much more realistic expectation of what was required. And that was, again, by looking at, introducing a much more friendlier process improvement flow pathway. Another one quick win that we used to get at the beginning was like looking at your drug round times, and people saying that they were getting a lot of interruptions and that during drug rounds, especially nurses. So again, by looking at reducing time spent and looking at reducing interruptions, again, by using this process improvement, we're able to actually reduce the time to the it taking place on our drug rounds. I think we're also keen that we're not just looking at where we're engaging with ourselves within the four walls of the hospital, that we have, we're constantly charged with actually moving our care across into community, having an integrated model of care. And I suppose one of the areas that we were seeing in relation to community referrals, that there was more and more time being spent on the hospital side in the actual referral pathway itself. It goes into a fax machine. There's about 10 different people who look at it. By the time you get back to the patient level, it's about 10 days later and nothing really has moved on. And I think, we worked with our community partners, and this was one of our earlier ones in relation to actually how do you put in place a much tighter process around the whole community referral pathway. So that was an excellent result. We were able to reduce that down to same day. So now we have a situation is when you send a community referral out, you got the same day response rate. And there's more further work being done in the community as part of the whole Unscheduled Care project. The next one was one where, I suppose one of the key components around what we were doing in the hospital was, it did impact on all services and all different aspects of hospital delivery. But I think one of the areas was getting clinician engagement and getting buy-in from clinicians, that this just wasn't an administration or a nice-to-do type thing, that, we were actually doing something that's valuable and putting time back into patient care. So we looked at a thrombolysis pathway, and very good engagement from our senior clinician in stroke care. So we were able to, again, by putting a very much pathway in place, improve our door-to-needle time down from 80 minutes to 48 minutes on average, and that actually has gone down to 30 minutes in the last 6 months. So this, this again is just an ongoing example in relation that it's not just about, the cleaning of the referrals. It actually does impact on patient care. One of the areas that we want to look at now, where we talk about the time is brain, that actually we want to look at something similar around our cath lab in relation to our PCI program in our cath labs. The hip fracture pathway was another one that our metrics around hip fracture and time to surgery was abysmal. There was a lot of different components, a lot of complexities in relation to how do we actually improve that patient journey and take the non-value added out of it. Again, this was a very good clinician buy-in example of a project. It was done last year as part of a Greenbelt project, and again, it's going into a second phase into this year. But again, we're able to look at reducing 24% increase of patients reaching surgery within 48 hours. We were only getting. We were in the red, to be honest with you, in relation to getting our patients to surgery within the 48-hour time frame. This has been increasing that. It's getting us into the amber and getting us into the green, but the most important thing about it is that it's improving patient care. And we're also looking at initiatives within it that, other disciplines of the healthcare industry, like the advanced nurse practitioner, can actually intervene here and expand their practice in relation to that pathway. I think looking at pharmacy again was another area who's done it, and how do you actually release time back to care? And this is where we released some pharmacy hours, hours released for pharmacy from nursing, where nursing actually was undertaking a lot of on non-value added work. This was some work that we did around our CT referral pathway, where we see an increase in CT order to report time, so there was a delay, I suppose, and when we get the CT order in relation to the report time, this is how we've increased the efficiencies of that, and again, reducing wait times for patients. Again, that's in our diagnostic orders, and this is another piece of work that we're doing in our stores as well. So I suppose that's just giving you a flavour really on, basically the type of work we're doing, and a big piece of work that we're doing in the Mater Hospital as well is around the unscheduled care pathway. And, that's the most complex pathway, I believe, but actually at the same time it's actually a very process-driven pathway in healthcare. And that is really, looking at that journey from the patient enters the front door to when they're actually discharged, either that into the community, back home, or into a long-term care facility. But as I said, it's very much alive. We have our third symposium next week in the Mater Hospital next Thursday. Each year it's a celebration, I suppose, of the projects that we're doing, of the amount of work that's actually been driven across the hospitals. And I suppose you'll ask me, that's great, all these projects, taking place in isolation, but how is that improving the operations of the hospital? Well, I would argue that I suppose what we're getting here is that by having a good governance structure in place, which I outlined at the beginning of the talk, where we have an oversight board which has got external people on that board. It's not just ourselves patting ourselves on the back saying you're doing great. Actually, we have people from, I have Leslie Doherty, the Bolton lady I spoke to you about, working on that board. We have somebody from Unpost on it. We have somebody from another institution and the university. So we're very much, I suppose, reality testing our work programme and how we're actually delivering it, and are we delivering the value added to patient. And one of the things now we're actually grappling with, it's great to have all of these initiatives and reducing that time to care and reducing the value add. But one of the areas that, I suppose two things in particular that's quite important is, number one, there's a piece of research around this that we actually didn't engage with on day one. We're very much involved in getting the programme initiated, getting the people engaged, getting the projects delivered, but actually what the outputs of that need to be evaluated, and they need to be collated, and we have done some publications around it, but we didn't actually start the publications early enough. So that's one of the areas that we're looking at in the new instigation of this as we move into the group. And the second piece, I suppose the most important area of that, is how do we put it into a control phase, because you can get into a spectrum where you're doing a lot of projects, getting a lot, and we are getting a lot of engagement. I'm not just saying that, it's very much people, we have a lot of people, there's a waiting list for people actually who want to get onto a green belt project, and it's not just sitting in a classroom and listening to lectures. It's actually getting out there onto the ground, lifting the bonnet, following patient pathways, looking at processes, and we also look at processes across disciplines. So it's not just one area looking at their own. You have a group of people where you have a number of people from different departments which is coming in and looking at other people's work. So it has engaged the staff. As I said at the beginning, I believe one of the key issues area of success, I think, is that it brings staff to the table who've never been brought to the table before and ask for an opinion. But what we need to do now is put it into control phase to ensure that we have sustainability. And I think what we're looking at now, that there is an element that instead of adding all the time, I think we need to actually control what we have, ensure that that is working and is becoming sustainable before we go into a second phase. And we're undertaking a strategy for the whole Lean Academy as we move into a group structure for the next 3 years. But I suppose from a hospital point of view, before I move on to the group level, I think there is very much a vision and commitment, and it wasn't just from me as the CEO at the time. It was from Professor Conor O'Keefe also, who's our Director of Quality and Clinical Director there at the time, and both of us had this, I suppose, really vision around how we can develop process improvement, how how you look at actually generating of data to look at what we're doing, supporting staff to tackle it, put a good education academia program in place, and develop that in-house expertise. I think that's critical, developing the in-house expertise to actually do that. And I suppose one of the areas that we've seen as well, and so if we talk to the Lean Academy back in the matter, what they are seeing is huge amount of data is being delivered across all of these programs. And when they're doing the Greenbelt projects, is that they're looking at the data, they're looking at their control phase across the data, and they're really analysing the data. But we have a huge amount of data, and I suppose now what we're talking about in the hospital, what are we doing with all of this data? It's even coming through from what you would call very on-the-ground delivery projects. That's not the data that the HSE are asking us to deliver, or some national data. It's actually data that's been delivered from the ground up, and actually what are we doing with that data, and how are we pulling that data together? And I think we've got a richness there in the hospital at the moment. We've got a huge amount of data that we probably just need to be a little bit more sophisticated in relation to how we manage that going forward. So I just want to talk to you a little bit, final part of my talk, I want to talk about the hospital groups and I suppose how we're trying to bring this process improvement into the hospital groups. Okay, sorry, I will. So the Ireland East Hospital Group, it's one of the largest hospital groups. There's 11 hospitals in it. It covers a population of 1 million. It's about 10,000 staff, and we have quite a number of GPs and that. So I suppose when we've seen from the data lately, we've seen statistical data around older persons, we know that the population is getting older. We know we're seeing more older persons attending in our EDs. We're also admitting more older persons. So we're looking at admitting, I think where a few years ago we were admitting 1 in 5, we're now admitting 1 in 2, and that's because we're seeing presentations from population which is over 85, so we know they're going to spend longer length of stay, but at the same time I think we need to have better processes that we're I suppose taking those patients out from the acute hospitals into appropriate beds. I suppose that's just sharing some data ourselves with our own emergency attendances. We're moving into another winter. Some people say winter never ends. We're seeing an increased number of attendances coming through. We saw a surge last year, and we're going to see another 4 to 5% surge this year. So, as we're saying, I don't think we can keep doing the same thing that we've been doing for years. I do believe there's an issue for beds, but it's not all about beds. So when we manage our unscheduled care programme, we have 6 emergency departments. We have one hospital that doesn't have an emergency department, but has a 12-hour urgent care centre. We have another hospital that actually has an acute medical assessment rather than an emergency department. So we're undertaking a piece of work that, I suppose, looking at how we are bringing this whole unscheduled, this whole process improvement flow process into unscheduled care. And I always say, I think this is we're starting a 3-year project. We've been at it for a year in the matter. We've seen some quick wins in the matter in relation to time to treat, time to triage. We've introduced specialty take in the matter, which is making some improvements, but bringing this into a 6th hospital is going to take time. It's also going to take patience, but we're hoping from some of the quick wins that we will get out of this, that we actually will be able to add it to the book of evidence to suggest that we need to get down into the process flows of patients coming through. As well as talk about it as well, it's not just we're doing from the acute system, but it's also looking at how we actually discharge our patients into post-acute care. So the transformation programme that we're doing for the group around process improvement is based on rapid improvement events. So that's really, it's slightly different than what we've done with the Lean Six Sigma. So there is another piece of research there to see, can you get actually better, more sustainable buy-in from doing Six Sigma rather than doing rapid improvement, or does rapid improvement actually give you quicker wins to make changes? The rapid improvement is actually taking a group of staff off a unit for a week. They have loads of data in that collected. You map the as-is piece of work with them. Then they intervene on day 3. They make the changes. Then they go back in and you do 30, 60-day evaluations, and you keep actually start introducing different levels of the pathway. So it's a huge amount of work involved. We have actually got some support from the HSE, the Health Service Improvement Project, to put in service improvement people across the group. And I've also engaged with Leslie again from her work in Bolton to actually become the external advisor into this work. But I suppose really, just as I said, We'll be starting this in the autumn properly, but we have actually introduced 2 pilot projects, one in the regional hospital in Mullingar and one in Kilkenny. Again, it's trying to get the buy-in of the whole transformational change for process improvement across the group. What we saw in Mullingar, one that we did during the summer, which was a very simple one about looking at eliminating waits for ultrasound and ED, where patients were admitted, waiting on the bed list, stayed on that, and then were discharged in the morning. So again, we introduced a dedicated ultrasound slots, reduced the non-admitted PET times, which is significant because we say if we can get into the non-admitted PET times, you can reduce the admitted PET times, and then reduction in the number of admitted patients there of 69%. So there's some really quick wins there, I suppose you're seeing, to get some engagement. And then on the Kilkenny side, what we're doing is looking at how do you, increase the whole predicted date of discharge, increase the 30-day review, increase actually how we allocate our patients effectively. So I suppose that really is is very much a synopsis of a very complex piece of work. I suppose the messaging I want to get across to you this morning was, I think process improvement can change how hospitals operate. You can get buy-in, you can get engagement. It does actually produce a lot of data, but you need to, I suppose, be conscious of how you manage that data. But it does need a research piece of work aside by it, because there's a lot of evidence being produced, and if you're not actually capturing that as a research in research methodology from day one, you're going to get lost into it. But I would like to come back here in a year's time or 2 years' time and say from the transformation programme and unscheduled care across the 6 hospitals that we have actually achieved some really good outcomes. And I think that's the last point I do want to make, is that the KPIs that we've been tasked with through the HSE in measuring unscheduled care is very much processed about time to triage, time to discharge, many patients waiting on beds. I think what we want to do, and what I didn't probably emphasise enough in the unscheduled care one, is actually we're introducing some quality indicators ourselves within the unscheduled care. So we want to look at crude mortality data in ED, patients waiting over 24 hours and trolleys, what harm can you do, looking at pure patient experience data, and looking at more valuable outcome data. And again, that takes a lot of data analysis, but I think working with UCD, we can hopefully achieve that. So thank you very much.